Hi, everyone. Thank, thank you for joining us today. We are very, very lucky to have with us some cardiology residents to present on some very interesting topics related to the heart in support of Heart Month. So my name is Lisa. I'm the clinical service lead with the chronic disease team here at the Wellness Institute. I work with pulmonary rehab and with cardiac rehab. So some of you are some familiar faces, most of you are, whether you're a member of the Wellness Institute or you're a participant in one of our programs, thank you for being here today. We are recording this for future viewing, so if you are interested, make sure that we have your email address before you leave, and I'll be able to send you out a notification of the recording. You can also find it on our website as well. So we'll kind of kick things off here today. So a couple of the topics that we have are, here we go, genetics and heart disease. What can it do and what can't it do? Presented by Dr. Nolan, Dr. Buse, and Dr. Wren. So we're going to kick off with that one first. Then we're going to head to what happens after SCAD. So that's spontaneous coronary artery dissection, presented by Dr. Shea and Dr. Griborio-Guzman. And then we'll end off with supplements for the heart, presented by Dr. Goyal, Dr. Sue, and Dr. Krishnan. If you do have questions, there will be a period after each presentation to ask questions. Please make them non-specific to yourself, so make them as generic as possible, please. And if we don't have time to answer all of the questions, then we'll have a question and answer period at the end as well. We also have a few prizes. So if you're interested in winning, we have a foam roller, we have a yoga mat, and the grand prize is $20, a gift certificate to the Mighty Kiwi, which is at our cafeteria here too. So I'll make a draw after each presentation. Perfect.
And then do I have to speak right into the mic?
You can support that.
I'm Claire. Hi, I'm Hongru. I'm one of the first-year cardiology fellows.
My name's Chris. I'm one of the third-year cardiology fellows.
And hi, I'm Hillary. I'm one of the other third-year fellows. It's nice to meet you all.
Thank you guys so much for coming to our talk. First, we're going to start our talk on the topic of heart disease and genetics, what it can and cannot do. So in general, to outline our talk, we're going to talk about what genetics are, what coronary artery disease is, and then the genetic associations between coronary artery disease and the risk factors of coronary artery disease, and then end the talk on talk of other heart conditions that are genetic and talking about home tests. So first, what are genes? Genes is the genetic material you get from your parents. Genes are organized into chromosomes, and you get 2 sets of chromosomes from each parent. So you can see here that you get 23 from your mom, 23 from your dad, you get 46 in total, and your genetics encodes the kind of like a recipe to make proteins, and proteins is what makes you grow, function, and provides you all of the traits that you have. It's not the only thing, and we'll talk a little bit more during the talk about what that means. It's not the only thing that determines what you look like and how you function. And also mistakes in these genes, we call mutations, can cause differences in how certain diseases happen or what other kinds of traits you might have. So the most important thing is that your genes aren't the only thing that determines how you're functioning or how your heart is functioning. The environment and your behavior really affects this. So, for example, twins might have identical genetics, but might look different, might have different diseases, have different allergies. And so one twin might develop heart disease and one twin might not, depending on other factors, mainly to do with lifestyle. So diet, exercise, whether they do certain behaviors like taking drugs or smoking. So we know that while you get your genes from your parents, and you share that with your family, we also know that families share similar lifestyles. And for that reason, it can be kind of difficult to figure out the exact amount that your genetics plays a role in diseases that are multifactorial, like coronary artery disease. So we know that people share this similar diet, they might like to play the same sports. We also know that families who have kids who have parents who smoke and families that smoke, they all tend to do that together. Okay, so what is coronary artery disease? Also, normally we call this heart disease. Coronary artery disease is problems with your heart arteries. Your heart arteries give your heart muscles blood so that they can function. A blockage that happens acutely or right away, we call a heart attack. But blockages can also happen over time very slowly. And so we call this coronary artery disease. So I really like what Dr. Nolan said at our last presentation. If you have water pipes, the water flows through, you open the taps, blood comes to your heart. But slowly over time, stuff might build up inside those taps. You might turn on the water and the flow isn't very good. And so when that flow isn't very good, people might get symptoms. We call that angina, so heart pain when people exercise. And that's because the flow through your pipes aren't very good. And what causes the flow not to be very good is atherosclerotic disease or cholesterol plaques that build up inside heart arteries. And so that's what coronary artery disease is. What we know about coronary artery disease is that there isn't one single gene that says if you have this gene or a mistake in that gene, you will get coronary artery disease. There's at least 200 genes that are associated with CAD, and altogether we can think that contributes to about 30% of the risk in someone with CAD. And so that doesn't mean that 30%, if you have one of these 200 genes, you have a 30% chance of getting it. It means that if you take a whole population, maybe 30% of those people's, everyone's risk is explained by genetic factors at all. And so in one individual person, it might mean a lot of their coronary artery disease is explained by genetics, or in someone else, it might mean none of their coronary artery disease is explained by genetics. Genes also don't predict the important questions people have. Will I get it at all? How severe will I get coronary artery disease? When or what kind of heart attack will I get? Genes can't, it doesn't actually matter how much genetic risk you have, we'll never be able to answer those questions. Well, what genes can tell you though is just risk. If you have more genetic risk factors, you're more likely to get coronary artery disease, though we don't know how severe or when.
So we're going to talk now about some of the risk factors for coronary artery disease and how genetics can play a role in that. So I've listed up here a number of the sort of more common risk factors, and all of the things that are bolded are, yeah, a little bit of up and down there between the two speakers. The ones that are bolded up there are things that can have genetics can have an impact in. Obviously, things like aging, smoking, exercising, those are not related to your genes. They're things that you can modify. The other things, there might be some genetic component to. So we'll go through some of those. The one thing, if you've been into your cardiologist or seen someone asking you about your heart health and your heart history, a lot of them will ask you if you've had, if anyone in your family has had heart artery disease at a young age. And when we talk about in the family, we're talking about first degree relatives, so parents, siblings, close to you. And that's because these people share similar genes to you. And we know that people who have family members who have heart artery disease at an early age, those patients are more likely to have increased risk. So I've listed there a couple of sort of examples. So if your father had heart artery disease at an early age, your risk is increased by 75%. If it was your mother, then your risk is increased by 60%. And if you have a sibling who has early heart artery disease, then your risk is increased by 40%. So you can see there's probably some genetic play. But as we talked about, these people are also probably people that you share a similar lifestyle with. So it's going to be a theme that keeps coming back. There may be some genetic play, but there's also a lifestyle play. High blood pressure is also something you've probably been asked about, or you may have. When we look at it, there's no single gene that causes high blood pressure. We do know that when you look at families. If there's a family history of high blood pressure, then you're 20% more likely to have that. But high blood pressure itself is highly influenced by lifestyle factors. And one of the big ones here is weight. We know that when people lose weight, you can lower your blood pressure. So while there may be a small genetic component, high blood pressure is probably a lot of lifestyle factors that are controlling it. A big one is cholesterol, and as cardiologists, we're very concerned about people's cholesterol. We send people for blood work all the time to check on their cholesterol, and we monitor it closely. And there have been a number of genes that are associated with increased LDL, or that's the bad cholesterol that we're looking at. But it's not as many genes as the 202 that we know of that make up the genes that increase your risk for heart artery disease. And most people's high cholesterol is not solely from your genetics. It's a combination of your genetics and your lifestyle factors. A couple of examples that are more heavily influenced by genetics when it comes to cholesterol. This little special guy here called lipoprotein A, or we call it Lp(a) for short. It's a type of cholesterol that's been associated with increased risk of heart artery disease. And this one actually does run in families. So it's been linked to one gene, the LPA gene. And so we know that people who have that gene, it runs in families, they're at a higher risk. And that risk that comes with having this gene and having a high Lp(a) level can't be influenced by lifestyle changes. So what does that mean? Well, if you have a high Lp(a) level, that might push your doctor to starting medications to lower your cholesterol if you weren't already on a statin or a medication like that. They might be more inclined to do that. They might be a little bit more aggressive at managing your bad cholesterol. And we're still following the bad cholesterol, that LDL, not the Lp(a) level. There are new medications that are coming out that can lower your Lp(a), but they haven't been shown to decrease your risk of heart attacks. So we still target that bad cholesterol. We just know that you're at increased risk. So we try and change what we can. The other condition associated with cholesterol that has a large genetic component is this big long name called familial hypercholesterolemia. I'm only going to refer to it as FH in the future. It's a genetic condition in about 1 in 250 people. It's caused by, again, a mistake in a gene that's passed down from your parents. So it's a large genetic component. And it causes very high levels of that bad cholesterol, that LDL. And so we know that because of that high bad cholesterol, people with FH are more likely to develop coronary artery disease. And diet and exercise alone in these people is often not enough to control the cholesterol. So even when we change our lifestyle factors, these people usually need to be on a couple of different medications to control their bad cholesterol levels because of this gene. Okay.
We'll do the final adjustment. So talking about diabetes, similar theme here. There's some genetic components and there's also some lifestyle components. I think everyone's probably heard of both type 1, type 2 diabetes. We typically think of type 1 diabetes as the diabetes that's diagnosed in children or younger people, and type 2 as the one that people develop with time. However, that's not a perfect rule. Both have genetic associations. So as an example, someone who has one parent with type 1 diabetes, they have about a 5% chance that they too will develop type 1 diabetes. If someone has two parents with type 1 diabetes, about 10 to 25% is the chance that they too will develop type 1 diabetes. Interestingly, type 2 diabetes is actually more associated with our genetics, and we're more likely to inherit it from our parents. However, type 2 diabetes is also more affected by our lifestyle choices, so diet, exercise, etc. Weight is more of the same, although, somewhere between 40 to 70%, 75% of our weight is genetic. So that's actually quite a bit. Some genes have been found, but we really don't understand these genes, nor do we have anything we can do about them. So we know that there is a genetic component to our weight. We can't really change that. We just can change the proportion of it that is based on our lifestyle. So again, the things that we've been reinforcing, the diet, the exercise. So those are some of the risk factors for heart artery disease or coronary artery disease and things that might affect your risk of having a heart attack that are based on genetics. We also wanted to spend a short period of time to talk about another heart condition that's caused by genetics. There's a couple others, but this is one of the more common ones. And this is just an example of a condition that is more heavily influenced by our genetics. We know that there's a couple of genes out there that very strongly influence something called hypertrophic cardiomyopathy. Basically, it's a fancy word meaning that you have a genetic predisposition to having a thick heart. So the muscle in your heart is thicker than normal. You may have read about this in the news. This is one of the more common reasons why young athletes will die suddenly. I don't know if anyone remembers Reggie Lewis. It happened, I believe, in the 90s, but he passed away from hypertrophic cardiomyopathy. And so what happens is that if a young person comes in, we find that they have a thick heart, we'll test their genes for this hypertrophic cardiomyopathy. And if we find that the genes are positive, we can then look in their family members, their siblings, children, etc., for this gene as well. And then we can treat those individuals before any symptoms or anything bad happens. So that's just an example of how it can be good for us to discover these genes so that we can treat people before it's too late. And finally, we just wanted to take some time to talk about home gene testing. This is becoming more and more available to us. And you see ads for this all over the place. I put a picture up here for 23andMe, although I think I found out recently that they might have gone under as a business, but before this was all over the TV. And so these things can be a lot of fun. For example, figuring out your ancestry, where people might be from. But if you go searching, you can find these tests to help diagnose basically any disease you want. And so this can be very confusing. And so we just wanted to take a second to mention this. So while this can be fun, I just want to caution you guys to be careful when you're doing these tests. So number one, as hopefully we've illustrated to you, genes are very confusing. Just because you have a mistake in your gene doesn't mean that you have a certain disease. So this test might come back saying you have a gene, but it doesn't mean that you have any disease whatsoever. And number two, you can have some sort of disease. For example, you can have heart artery disease, and you might not have any genes related to it. So it's just a very confusing thing. The second piece is that these tests provide you with the fact that you may or may not have a mistake in your gene, but it doesn't really tell you much else. And so you'll get this information, but it might be confusing what to do with it. The other thing that I hope we've conveyed to you is that genes affect you and they affect your family. So if you get information about your gene, that also affects the people around you. So just be careful about that. The next thing I want to point out is the accuracy of these tests. Some of them are more reliable than others, so just be aware of that. And the final thing is that these companies are going to be taking your information, read the fine print, find out what they're going to do with your personal information. So is it all hopeless? The answer is no, it's not all hopeless. Only about 30% or up to 30% of your risk of coronary artery disease is genetic. And so that means that there's 70% or more of things that you can change. So these are diet, exercise, lifestyle, stopping smoking, all of those things. So while genes and your genetic risk can help us figure out what your risk is for having a heart attack, it's not the whole picture. And so that means that there's a lot of things you can change. And so that's sort of the important part to focus on. So that's the presentation. If you guys have any questions, we'd be happy to answer them.
One, two, three. Hello, everyone. My name is Shay. I'm one of the second-year cardiology fellows.
Hi, I'm Andres, or Dr. Griborio, internist, trained to be a cardiologist, first-year fellow.
And we're going to talk about spontaneous coronary artery disease. Andres will kick us up.
So we're going to talk about SCAD, and you'll see what that stands for, but think of it as it is a heart attack, but kind of another kind of heart attack. We'll see why it happens and who gets it. So SCAD stands for spontaneous coronary artery dissection. So spontaneous because it happens without any trauma, any like external injury or any interventions to the vessel. Coronary are the vessels, the arteries that feed the heart. Coronary comes from crown. Artery are the vessels that bring the oxygenated blood. So coronary arteries are the ones that bring the kind of oxygenated blood to the heart. And then dissection, meaning like a tear or a separation of the layers. And we'll see how that happens here. So, well, if you see the picture, remember we saw the picture of the coronary artery, the one that was like clean, that had no cholesterol, plaque buildup, and then we saw another one next to it that had some cholesterol. And SCAD, for most part, there's no cholesterol involved in it. It's more of a bleed that happens between the walls of the artery that makes the innermost layer of the artery to tear. Then that tear happens, and as blood flows, you'll have the flap kind of obstructing the blood flow. When you have no blood flow to the heart, that's a heart attack. That's a myocardial infarction. So you can see how it's a heart attack in the sense that you get no flow to the heart, but it's not from cholesterol buildup. It's from a tear or a bleed in the layers of the vessel. Okay, so still ends up giving you injury to the heart. I can skip the video. So then, how often does it happen? So SCAD is rare. Well, 1 in 20 at most heart attacks are caused by SCAD. Yeah, and women are 9 times more likely to get SCAD. So again, most people with SCAD would be women, and it looks like it presents like a heart attack. Still, the most common symptom of SCAD is chest pain. More than 9 out of 10 would still be chest pain. But you can have other symptoms or associated symptoms, chest pain plus something else, or no chest pain and one of these. So pain in the arms, shoulders or jaw, back pain, nausea, vomiting, sweating, feeling short of breath or having difficulty breathing, feeling dizzy or lightheaded, or feeling you're gonna faint or pass out, feeling fatigue, headache, fainting, palpitations, heart racing. All these things can be the symptoms you have with presentation of a heart attack, either SCAD or the traditional cholesterol heart attack. That way. And then, how's it diagnosed? So, 3 main things: blood work. So, some blood tests at the hospital that will tell us if there's like injury to the heart muscle. Electrocardiogram and coronary angiogram. And with the electrocardiogram, we can see. We can do this. Yes. Yeah. So electrocardiogram will be here. Important thing on electrocardiogram: if you think you're having a heart attack, if you have chest pain, if you have a heart attack, we suggest to everyone to not drive to the hospital, call 911. And there's many reasons why that's helpful. Even like for you as a patient, the paramedics can do an electrocardiogram at your place, at like wherever they find you. And that electrocardiogram that test will be sent to the team of cardiologists at the hospital, and they will help the paramedics to determine is this a heart attack that is like a heart attack. Does it need to come right away to the cath lab where they do the angiogram? So if indeed you need to have those things done quickly, you can basically kind of bypass the emergency department, and you'll get the paramedics bring you straight to the cath lab, which saves time, which saves muscle, which saves the heart. So again, if you think you have a heart attack, call 911. Don't drive yourself to the hospital. And this is how it looks when they're doing an angiogram. Now, SCAD is associated with different diseases or different other things that patients can have. There's one big one that's called fibromuscular dysplasia, and up to 4 out of 5 patients with SCAD can have FMD. You can see how this is, I guess to the left, how a normal vessel looks. Vessel with FMD will have these bumps and lumps, and this is not normal, and this will predispose these vessels to tear or bleed in the walls, and then have SCAD or have dissections in other vessels, not just the heart, but where you find these issues. This is what looks in an angiogram. So yeah, these lumps can tear or, well, if there's aneurysms. Anyway, then there's migraines, and up to half of the people who've had SCAD have also had migraines. This does not mean that if you had migraines, you're going to have SCAD. or that everyone who's had like have migraine have SCAD. No, it's just an association, and it's again something that if when you see your doctor when you're in the hospital and you're having a heart attack and we think, oh, this might be SCAD, we're going to ask this kinds of things. Oh, have you had migraines or those things, right? And other risk factors too. Connective tissue diseases or others. This picture's here on the right. This is lupus. This is Raynaud phenomenon. This is more like hypermobility and skin issues. And this would be the diseases associated with SCAD would be things like Marfan disease or Loeys-Dietz syndrome, those things. This skin/immunological diseases, which are many, have been related with SCAD as well. And the age of patients who get SCAD, it is different. It usually tends to happen in younger patients, and it tends to happen, it happens to both men and women, more in women, as we said, and the mean age, it's been calculated at 52. This SCAD heart attacks, if patients are pregnant or have just delivered, so that's a postpartum period, and they have a heart attack, they're usually caused by SCAD, not by your traditional cholesterol related heart attack. So then being pregnant or being postpartum can be a trigger or a predisposing factor for having this kind of heart attack. And part of it might be explained by hormones. Same way that when patients are pregnant, people are pregnant, they have a higher level of hormones. Other hormone therapies or having more hormones in your body will predispose you or trigger this kind of heart attack. So things like in vitro fertilization, oral contraceptives, hormone replacement therapy for things like menopause and hormone therapy and transgender individuals, all those things that have hormones, like the high hormones patients have while they're pregnant, they can also predispose patients to SCAD kind of heart attack. Sudden mechanical force or sudden, let's say, weightlifting can be a trigger. It's that, again, does not mean that if you're lifting weights, you're going to have a SCAD heart attack. That means that if you have the other risk factors, you have the predisposition, if your vessels have this, these factors that make it predisposed to have this kind of heart attack. And some people have had SCAD or SCAD heart attacks after lifting weights, for example, or use of mechanical force. Part of the recommendations would be to not just reduce how much weight you're going to lift. I'm going to go to that later, but also warm up when you're doing physical activity. How to treat it? Most of the time, the artery heals on its own, and for SCAD specifically, there's no need for intervention. Most patients with SCAD do not need stents, do not need bypass, and in fact, these, except in rare circumstances in which there are other risks, it can harm because you can extend the tear in the vessels. So most times, this coronary arteries heal on their own. It's been said that last one by the month, and then up to 6 months, like more than 97% are healed. So again, for most people, we just let the artery heal on its own. Think of it as a bruise inside the vessel. If you let it heal, it should be fine. Other things we can do to treat it will be control the heart rate, for which we take some medications called beta blockers. Should reduce your heart rate or do not allow it to go very fast. Aspirin, avoid triggers, which we just talk about, and then control pain, which we're going to talk about later. So life after SCAD, Dr. Rizi.
Thank you, Andres. So we talked about SCAD as a very rare cause of heart attack, that instead of a blockage from, calcium and cholesterol buildup and a blood like clot, the blockage happens when the arteries on top of the heart actually tear on their own. And that tear may cause some blockage through the artery, and that's how it can feel like a heart attack. Now, we know that patients with SCAD are usually younger. They're usually female. They might be at the peak of their careers. They might be in childbearing age, plan to extend their families. And these all can be a lot for a person. A lot of questions arise as, what changes can I make to my lifestyle? It could be very anxiety-provoking. What exercises can I do? What activities can I do? What can I eat? What can't I eat? There's a lot of questions, and there's a lot of anxiety-provoking uncertainties. We have some answers for some of those, and we're working on some answers for the rest of them. So activity is a big issue. We know that one of the triggers of spontaneous dissection of coronaries or SCAD could be a very huge load on the body, like lifting 200 pounds or like a jump start of the running or something like that. But that doesn't mean that a person with SCAD should say goodbye to gym and live a sedentary life. Cardiac rehab facilities are actually one of the best things that have proven to make the life of patients with SCAD better, because they provide people with a very nice and individualized exercise program, in addition to education about what they can and can't do, in addition with counseling and a sense of community. In fact, it is important to exercise, but we should be aware that we want to basically stay away from activities that raise the heart rate or blood pressure too much. For somebody who's 60 years old, the maximum heart rate that is allowed for them or they can achieve is about 160. So in SCAD, after SCAD, you don't want to increase your heart rate anything more than 120. You want to keep your blood pressure always nice and low, below 130. Now, these have implications. For example, we say that for men, they should not weigh heavy weight more than 50 pounds. For women, they should not lift any weights more than 30 pounds. But that doesn't mean that they can do lower weight. We need to, incorporate some strength training in order to keep our bones and muscles healthy. In fact, it is very strongly recommended that we participate in cardiac rehab programs with moderate cardio and aerobic activities, start weight training with low resistance, 1 pound, 2 pounds, not jump to the 20 pounds at once, and continue being active. Stuff like endurance exercise, like aerobic training, like longer runs and stuff like that should be approached with caution after we talk with our counselors, rehab, and cardiologists. But there are exercises to be avoided, such as things that require an explosive movement, an abrupt movement, heavy weightlifting, and contact sports. Mental health is a huge thing after any life-changing disease, especially a SCAD. It happens in younger patients. It happens in younger women. They're thinking about their jobs, things that they can't do in their jobs anymore. They're thinking about their reproductive health. These are important and very anxiety provoking. We know that there's a high rates of anxiety, PTSD, and depression after heart attack, and more than that in a patient who's young and now suddenly being told they can't do a lot of things in their life. The first kind of step is for all of us to acknowledge those emotions. As physicians who take care of SCAD patients, we need to make sure to understand that that's a very normal part of the human body reaction. As people who go through this life-changing event, we need to acknowledge those emotions and make sure that we know that they're normal and there are ways to deal with them. What about diet? Diet for a lot of us is the easiest way to control our lifestyle. And a big question is, are there any food that we can or can't eat after SCAD? Unfortunately, there is no research or any evidence-based findings telling us that we can't eat anything after certain types of food after SCAD, or certain types of food that can prevent SCAD. There are some, reports here and there kind of discouraging people from consuming large amounts of caffeine, but they're not as strong, and a coffee here and there should not be a source of anxiety. But what we have very strong evidence is against smoking. If somebody has smoked, they should very seriously think about quitting. And if they haven't smoked, that's awesome. That's the best thing that they could have done for themselves. Much similar to traditional heart attacks, smoking causes inflammation in all the vessels and basically increases the rates of both heart attacks and tearing or dissection or SCAD. In terms of alcohol, there is no robust data on how much we can of a direct relationships, but what we know from studies is that limiting alcohol intake is helpful to prevent a recurrence. Another kind of piece of hard evidence that we have, recreational drugs increase the risk of dissection in any types of vessels, including the vessels on top of the heart and the vessels in the brain. Things like cocaine, meth, or uppers actually increase the risk of dissection and SCAD. With legalization of marijuana, a big question is, does that affect our heart health? We don't know this completely yet with, large trials that show this in a robust way, but we have seen observed in studies that marijuana actually has been linked to dissection and SCAD. So as a physician, I will discourage my patients from using marijuana. What about pregnancy? We know that pregnancy and being a woman right after delivery is one of the biggest risk factors for SCAD. Pregnant women who have SCAD during their pregnancies often have a more severe version of the disease. It can cause a lot of disease after pregnancy and even death. So the current recommendation is that after a SCAD, women are discouraged about pregnancy. It's not recommended for them to become pregnant again. If they become pregnant, it is highly recommended that they should see a cardiologist who has expertise in managing patients with heart disease during pregnancy. Contraception is also a big thing. The first thing for a contraception agent for sexually active adults is that they need some method that it works based on the things that we know that we don't want SCAD patients to become pregnant again. We also have evidence that contraceptive methods that include estrogen, like combo pills, they are not recommended as they can increase the risk of SCAD. What about pain? Often on patients and women who have had SCAD experience a lot of pain, especially in the first 6 months after their original event. The fear is that, what if I'm having another episode? And in fact, in the first 3 months, that's the period of time that the probability of having another episode is the highest. But the silver lining is that overall, probability of having another episode becomes lower and lower until it's about 1 to 3% in the first 3 years after the initial event or after the initial heart attack. If somebody after a SCAD is having a lot of pain, a very severe chest pressure, something that's unrelenting and increasing, they should immediately care medical attention. They should call 911 and go to the hospital. However, after a while, when the patient starts to know their body, they realize that like 90% of these pains are not actually from a heart attack. Most of these pains are coming from healing of the artery, and that's a good thing, which will go away after a while. It is important to kind of keep those things in mind and know when to seek medical attention, listen to your body, and also know that when the pain is not coming from a heart attack, we could still, make it better with other types of pain control, with mindfulness, with a very good relationship with you, yourself, and your physician. So despite all the terrible news that we had so far, the silver lining is that most of the SCAD patients actually go back to their to living a normal life and going back to most of their activities. Unfortunately, they still should stay away from, lifting heavy weights or pregnancy. But other than that, acknowledging those differences, they can go back to a full life. I just want to echo the sentiment that Andres has said. If you think that you're having a heart attack, please do not drive to the hospital. Please call 911 for some reason. The first thing is that it mobilizes forces if you need urgent intervention, such as coronary angiogram. And secondly, it would be safer for you to call 911 rather than driving yourself. Thank you very much. And I want to leave you with this resource, which is basically a peer support group for Canadian Women's Heart Health Alliance. They have representation in Manitoba, and it's a fantastic resource for women who've had SCAD. I'm concentrating here on women because, as we said, 90% of patients with SCAD are women.
In Zoom world, can you guys see the slides progressing? Just come and comment in the chat if you can. Okay, perfect. So hi there, my name is Dr. Goyal. I'm one of the cardiology fellows at St. Boniface.
My name is Dr. Sam Su.
So we're going to be talking about supplements of the heart. So this is a big topic, and we can't cover every supplement that's known to mankind for your heart, but we can definitely comment on some of the more common ones that we see in pharmacy aisles. So the purpose of our presentation is to discuss the few commonly reported supplements for heart health, provide a general framework on how to be a good judge of information that you read, what are good sources, what are bad sources, what should you believe, what shouldn't you believe, and provide some recommendations on which supplements are backed by science and which ones may be actually useful for the heart, which ones are not useful for the heart. The do's and don'ts of taking supplements, and then answer any questions to the best of our ability that you may have regarding cardiac supplementation. So the amount of information out there can be absolutely overwhelming with Twitter, Facebook, Instagram, all the different social media outlets that we all have access to. There's people posting stuff on there that might be doctors, might not have any credentials. So it's really hard to know what to believe and what not to believe. So it is quite a difficult place to navigate, and it's hard for even us. So with vast amounts of reported supplements out there, it would be impossible to discuss each one today, as I stated. Therefore, we hope to give you some tools so that when you come across information about various supplements, you can try and navigate that yourself in a way that can be helpful to you to discern, is this information credible or is it not? So some of the important questions that we have to ask ourselves when we're looking at any information that we see is, who's the actual author of the article that we're reading? What are their credentials? What is their education? Is it somebody who is from a Joe Rogan podcast who is talking about a supplement that they might have invented, that there's monetary gain to be had from their supplement? Is this person a scientist from Johns Hopkins who's talking about new research that's come out in the New England Journal of Medicine? So all of these things really matter with regards to who's authored the actual article that you are coming across. The next question is the information published somewhere? Is it just a tweet that you saw somewhere, or is it published on the Canadian Society of Cardiology or the American Heart Association? These are all things to take into consideration when looking at articles that you're seeing or information that's being printed out there. The next thing is, can the information be trusted? One good way to do that is to see, is the claim that's being made supported by multiple different resources. If you see one website that says that this one supplementation is the best thing for your heart, can you reproduce that on multiple websites or multiple places? If many different places are giving you the same information, then that information has a bit more credibility to it. And lastly, you can always go to your family doctor or your cardiologist and mention the supplementation that you're thinking about taking or the one that you are on to get some more information from them to see what their expertise would be. So here's a little framework that I found online. The first one's talking about sensationalized headlines. If very bold claims are made by a supplement to say that it can cure your heart disease or cure your coronary artery disease, I'd be very skeptical about that. Because if that was the answer, then we would be doing it for our patients on a day-to-day basis. If we had easy answers on how to cure some of these diseases. The other thing is misinterpreted results. A lot of times you might see a part of a very long 40-page study where one table is taken out and plastered all over the internet. That table out of context can be interpreted to mean many different things. Without reading the full article and understanding the context of that information, it can be sent in various different directions to promote whatever agenda is being promoted. So it's important to look out for that as well and look at the entire resource rather than just excerpts of a resource. The next thing then is conflict of interest. Unfortunately, money does make the world go round, so there are a lot of people that are selling stuff out there and putting claims on different bottles that it helps with this disease or that disease. If you walk down the aisle at Shoppers Drug Mart, there is a whole array of cardiac supplementation that varies from prices from $5 all the way to $50. So there are some monetary gains to be had. Not to say that all of them are not helpful or completely useless, but just to be cautious of that. Is the person who's putting this information out there, do they have monetary gain to be had from what they're putting out there? So given that, we'll talk about two common vitamins that you might have come across or heard of. One is coenzyme Q10 and one is resveratrol. We'll talk about both of these in brief detail, and then I'll give you some general guidance on if they're worth taking or not. So the first one is coenzyme Q10. What is coenzyme Q10? It's an antioxidant produced by humans naturally. Its levels decrease in your body as you age. It's found to be lower in patients who are on statins. And most of our cardiac patients are on statins, so that's an important point. It's found in foods such as meats, fish, and nuts. It's available to take as a supplement in capsule or liquid form. You can see all the various preparations there that are sold at the stores. There's many, many iterations of coenzyme Q10 that you can find. But in conclusion, the bottom line is the actual supplement is safe to take for human consumption. If you see all the statements here, they're may statements. It may help in heart disease. It may help in heart failure. It may help reduce LDL levels. None of this is backed by big double-blind controlled trials to suggest it's actually helpful to people that have heart disease. So the Canadian guidelines and the American guidelines both do not recommend starting coenzyme Q10 for actual heart supplementation for benefit. That being said, there are some early studies that could show potential benefit, but nothing conclusive in a large trial format that shows that coenzyme Q10 is helpful. There is a caution as well with coenzyme Q10 that if you're taking the supplement and you get put on a blood thinner, specifically warfarin, please mention that to your healthcare provider, whether it's your cardiologist or your family doctor, because coenzyme Q10 with warfarin could reduce the effectiveness of the warfarin, which could be a problem if you have a heart valve or you have AFib and you're taking it for a clot purpose. So do mention that to your physicians if you are on coenzyme Q10. The next supplement out there that you hear about is called resveratrol. It is found in foods such as peanuts, grapes, and berries. Has anyone ever heard that red wine is good for your heart? If you have heard that, that's kind of where that comes from. Resveratrol would be the active component. So by the end of this quick talk, you'll be either drinking bottles of wine or not, and we'll get to that. So the amount of resveratrol in food is in very, very little amounts that don't actually have much effect on the human body, and it is mostly excreted in the urine. So for resveratrol, there are some small animal studies that have shown benefit to this supplement. It's unknown what its application is in humans. Something that could work in animals is not always translatable to the human population. So bigger trials are still needed to fully ascertain if resveratrol is helpful in human adults. The human trials have not been able to conclude that yet. There have been a couple, but no major positive effects were seen in patients with heart failure. So I'm sorry to burst your bubble, but drinking bottles of wine is not going to cure your heart. So here's an example of an excerpt that comes from an article. And if you were to just see this online, it says resveratrol in the middle, and it points towards how it's helpful to your pump function of your heart, how it's helpful to diabetes, how it's helpful to hypertension. This is a proposed mechanism of how resveratrol could potentially help, where more studies are needed. So taking this and saying, oh, I saw an article that showed that it helps in all these different ways, and I'm going to drink all the wine now, is a bit of a misinterpretation of the data. So that's just an example of how you might be led astray. So the bottom line for resveratrol is that there's no proven benefit in humans, depending on the studies that have been done so far. More studies are still needed to see if this is actually a helpful supplement. So therefore, there's no strong recommendation to take resveratrol supplementation in capsule form for your heart health. I'll hand it over to Dr. Su.
Last mic adjustment. So my name is Dr. Sam Su. I'm shorter than Dr. Goyal. I get the task of taking you guys through the home stretch here. Before I start out, maybe I'd like to give a shout out to the gentleman in the front row, who I think wins T-shirt of the Day award. Maybe you could stand up and maybe show everyone your shirt, because it's the kind of humor that I think we all appreciate. Thank you. So I get 3 difficult tasks, and the first task that I have been assigned is to follow the talks of all these smart doctors. So that's task number 1. One of these, who is a Wellness Institute living legend, Dr. Goyal, who started his early days playing basketball as a young child, and is now almost a full doctor in training, a few years away from finishing. So that's a big first task for me. The second task that I'm going to take you through is I'm going to be delving into the world of herbal supplements, green supplements, extracts, teas, and things like that. And then finally, we'll finish off by talking about fish oil supplements. So supplements, herbal supplements take many different forms, shapes. You may see them being seen as teas, capsules, or powders. Many have been proposed as healthy for the heart. And to name a few examples, there's green tea, turmeric, garlic, ginseng, ginger, hawthorn, cinnamon. That's only to name a few. And so I'll talk about a select few. Now the gist of these is that they're viewed as healthy because they're green or they're natural. And so there's no way that they could really be unhealthy. But the question I really want everyone to think about is which of these will actually provide you benefit for the heart. Now, we've heard a lot about supplements that don't work. Now, maybe let's start by talking about a supplement that does work. So this is a big success story in terms of herbal supplements or plants. This is a plant here, this pink flower here. It's called foxglove. And the technical term is Digitalis purpura. We know it as digoxin. Now, maybe show of hands, who has heard of digoxin or knows of somebody on the medication digoxin? So pretty good number of people in the room. We commonly use digoxin to treat 3 main things in cardiology. We use it to treat irregular heart rhythms, atrial fibrillation or atrial flutter. It's where the heart beats irregularly and fast. And we also use it in the world of congestive heart failure, or CHF. Now, there have been many large trials with thousands of patients who look at the use of digoxin. It shows that it improves the quality of life for people who suffer from these conditions. And in 2021, there were more than 1 million prescriptions of this medication in the US. So this is a story of how a plant made its way all the way to big pharma and is now a commonly prescribed pill that a lot of people in the room knew about. Now, not all supplements have the same success story as digoxin. The next supplement that I'll talk about is ginseng, or Panax quinquefolius. Now, the active ingredient in ginseng is ginsenosides. Now, there are a lot of proposed benefits of ginsenosides. And these range from things like benefits for cancer, osteoarthritis, osteoporosis, inflammation, can be neuroprotective. And in our world, there have been proposed benefits in terms of heart conditions and diabetes. And it's one of the most widely used herbal medicines with very wide proposed ranges of use. Now, in our world, it's been proposed to improve circulation, and alter your cholesterol or your lipid profile, and therefore has been proposed to have cardiovascular benefit. Now, the big thing to ask yourself is, are these studies showing benefits in terms of real patients, or are they showing proteins in the lab, or are they showing proteins in animal models? And so I think that distinction needs to be clearly made. So we delved into a lot of the research about supplements and kind of sifted through the data so that you don't have to. And so we're hoping to give you the bottom line of all our hard research. And so in terms of ginseng, many of the studies have been done in animals, unfortunately, with very few actually done in humans. Some studies show that it does suggest some blood pressure lowering effect. And some studies suggest that there may be benefits in terms of altering your lipid profile and lowering your sugars. However, these were all in animal models, and I don't see any mice in the room. And so, fortunately, the bottom line is that there's really no good quality evidence to support the use of ginseng in anyone in this room. The next plant that I'd like to talk about is called Crataegus monogyna, otherwise known as hawthorn. Now, these plants start as flowers in the springtime. You see these white flowers here. In the summertime, they blossom into these nice red fruits, and these are known as haws, and that's why they're called hawthorns. Okay, so this might be mixed up into a powder or into a tea, and it might make its way into an active ingredient in one of the pills that you may find in a lot of the supplements over the counter. So if you read the pill bottle, you might see something like hawthorn. Now, it's proposed to have antioxidant properties, antiarrhythmic properties, improve coronary blood flow. It's a vasorelaxator. It improves cardiac contractility. These all sound like great things, hey? Now, what happens when you look at these, the use of this supplement in actual patients? So a large trial called the HERB-CHF trial looked at hawthorn use in patients with congestive heart failure as an add-on to the already kind of overwhelming data of medications. So in patients who are on optimized medical therapy, if you added on this supplement, they looked if there was any benefit. Unfortunately, the bottom line is that there was no difference in outcomes between patients who are not on this medication and on this supplement. Therefore, the American Heart Association does not recommend its use over standard medical therapies. And in fact, things like hawthorn supplements or hawthorn containing supplements may be actually costly. And if your financial situation is difficult, I know everyone's is different. Actually setting aside a part of your budget to actually afford the hawthorn may take away from your ability to afford some other medications. And so we can't recommend its use over just standard medications. The final thing to know about hawthorn is that it actually interacts with the medications that we know do work, like digoxin. So you remember that success story that I talked about a few minutes ago? So this hawthorn supplement actually has an interaction with this, and it's not recommended that you use these two together. Okay, so task number 3, I'll be talking about the world of fish oils, omega fatty acids, and these are commonly found in fish and oil. And the context that I want to be talking about here is in the pill form. So it's nice. It's fine to enjoy a nice salmon as your protein for a meal, but the context that I'm talking about is actually going over the counter and buying fish oil pills and taking these. Omega-3 fatty acids are essential polyunsaturated fats found in certain fish oils and plant oils, and there have been proposed benefits for cardiovascular health. And a thing of the past was that it was very highly recommended for cardiovascular health. This is a picture showing 3 omega fatty acids with very long names. I will call them ALA, EPA, and DHA. If you want me to pronounce them and make a fool of myself, I'm happy to do that. But I think for the purpose of this talk, I will continue on referring to them as those. The body converts these omega-3 fatty acids between each other, and that way can alter your lipid profile. Now, ALA is found in plant oils. DHA and EPA are found in fish and other seafoods. This is a great picture here showing that omega-3 fatty acid sources can include fish, flaxseed, walnuts, and edamame, which I think are all fine things to include in your daily diet. But does supplementing any of these active ingredients add any benefit? Supplementation of these compounds are actually very widely available. They can be purchased over the counter with any sort of prescription. Even going to Costco the other day, there's like 3 different options of these. So what's the evidence behind these fish oil supplements? So previously thought that there would be some benefits. The proposed mechanisms are lowering triglycerides and thereby lowering the incidence of heart attacks and lowering the risk that you actually die from a heart attack. And that all sounds good. Now, similarly, these fish oils have been shown to reduce your triglyceride levels by blocking the production of very low density lipoprotein in the liver. Now, does this actually reduce the number of heart attacks when you give this pill? And that's the question. Now, a large trial looking at thousands of patients looked at this specific question, and they looked at whether patients were on it and not on it. Ultimately, the results show that there is no benefit from fish oil formulations and added supplementation of these over standard medications. So I don't think we have enough data to support its use fully in current day. And actually, there was an adverse effect. Patients who were on fish oils actually had a higher incidence of something called atrial fibrillation, which is that irregular, can be bothersome heart rhythm if patients were on fish oil supplements. So bottom line, I can't recommend, and we as a society cannot recommend fish oil supplements. And actually the Canadian groups, the American groups, and the European groups all met together, and they all agree that we do not recommend routine fish oil supplementation in lowering your cardiac risk. So I hope I did a decent job in all three of my tasks. The takeaways of our presentation today are that many supplements are available. Many have been reported to have cardiac benefits. I think it's important to critically analyze all the data when you look at supplements for your own use, as not all studies are designed the same way. As I mentioned, there are studies looking at proteins, there are studies looking at mice, and then there's studies looking at large groups of patients like yourselves. And I think finally, if you do find yourself in a world of taking supplements, I think it's important that you are very clear with your medical team that that's what you're doing, so that we can check to see, the safety of this supplement, as well as any interactions with the medications that you're currently taking. I think bottom line, transparency is key.